first lecture now is on multi-planar osteotomy and key steps and its soft tissue impact. Well, that is a topic that you've given me that could easily cover or fill a whole osteotomy congress of a couple of days. So obviously lots of planes that we need to talk about, and as there are many planes that we talk about, there is many implications that we see. So when you look at malalignments, then obviously you can look, let's say here, like from the frontal plane, and then there is a rotational plane. And the problem is that for some of these planes, regardless whether you look at the left hand or the right hand from your side image here, as if it's the sagittal or the frontal plane, it actually is directly seeable that there is a malalignment. Whereas when you look at the rotational profile, it's not. So this is a problem because the rotational profile does not really reveal to the eye and therefore has lots of implications that we don't understand. And then there are some structures that are associated with this non-understood profile that actually it makes it even more complex because all these implications are then multifactorial, as you can see. So let's say looking at this rotational profile, I don't want to really cover all the implications that it has to the patella and all that stuff. Let's focus on our bread and butter work here, and that's what I'm doing. Only to clarify, because rotation and torsion and version is actually somewhat interchangeable in literature, and it goes a bit weird. And the problem is that most of these terms are used as umbrella terms. So just to make it very clear, because I think it's worth looking at it when we talk about planes, then obviously there is a rotation in one of them, and rotation is always dynamic. And as I said, it's interchangeably used for torsional deformities, but it acts as an umbrella term. Version is actually the normal difference in angulation between the proximal and the distal part of a long bone. And it's static. Version inside of a bone is not moving at all. And then there is torsion. And this is the version outside to standard deviations. So version, in fact, is the pathological state of torsion is the pathological state of a normal version. So looking at this now, once again, and that illustrates it better. So that what you see here is actually rotation. That what you see here is the normal torsion in the bone. And that is the pathological state outside two standard deviations if we now move it. See it here. Should be coming. Yeah? So just to explain those words, because that always drives me mad when I hear that. So nonetheless, let's talk about the soft tissue implications. So in a frontal plane deformity, it's quite a logical thing that obviously the deformity itself puts strain on the ligaments that you see or the capsular components where the ligaments are connected to or may not be connected to regarding on what joint you look at. But these implications are all well known to us. If you look at such a chap here walking after multi-lig injury, still after ligament reconstruction, having this thrust, obviously and probably overseen posterolateral or not really well fixed posterolateral corner injury that leads to this situation. And we all know this concept of the normal primary varus. You might be having the double varus that you see in such a scenario that may develop eventually to a triple varus deformity. So that has nothing to do with the deformity in itself. It's actually the ligamentous response to the deformity. How to deal with this now? Well, as it's sometimes hard to deal with the ligament itself, as you may have seen here in this lab, what you can do is you can change the underlying deformity. And by changing the underlying deformity, you can change the thrust and therefore the secondary deformity that developed on top of this. So we all know these sportsmen, like here, that is Litbarski, actually a German player that got only famous for his bow legs. And that is Malcolm MacDonald, former national for the English, whom we met in Newcastle and had the chance to chat to him. Wonderful bloke. So obviously quite varus. And well, there is lots of science now on why soccer players are varus. In fact, I just believe that they are soccer players because they are varus. Because we can see the other way around, it works in a valgus alignment when you look at rugby players. And I guess the reason is because these lads are quite heavy at young age, and so they actually stay in their knock-knee deformity. So you see lots of rugby players being knock-kneed. And I don't really think that this is beneficial for the sport itself. It's just the physical conditions that you see these players at that has a positive effect on the sport. So let's look at the sagittal plane, and that is now an interesting field because that's not that obvious, and only in the last like 15 years people started to look at it, and it's a quite easy thing to understand. And if you imagine that the femur is actually on a slope, the higher the slope, the further the femur rolls back, and the fewer slope you're having, the more it's stabilized in the front. So there is this is nice because that's a Schlesinger ball, and that is the ball that was used in 1966 in the World Cup finals when the English stole our title. So that's why I have it there. It's always there to remember me. Yeah? Okay, so let's look at forces that we can measure based on the slope here. Obviously, with any slope and slope change that we see, there is a translation force that goes along with this. So, and you can see here in this animation that if you are reducing the slope, extension osteotomy, then you remove strain from your ACL. And the same is true for the PCL. And my former colleague Jens Agneskirchner made this beautiful study, actually. I think it's a landmark study. And he has there proven in a biomechanical bicardiac apparatus that actually you can transfer forces by changing the tibial slope. And so he did this, and he took these knees, transected the PCL, and measured the forces and the translation that the tibia had under the femur. And he did this with a flexion osteotomy. So obviously he put strain on the PCL. So strain on the PCL, flexion osteotomy. And you see there at the left-hand side, PCL transected without osteotomy, you already have a posterior draw. Quite an obvious thing. So then you apply your flexion osteotomy, and with 5 degrees of flexion alone, it transfers it from a posterior draw to an anterior draw. 5 degrees is enough. So 10 obviously leads to 2 millimeters of anterior positioning, and then up to 20 degrees of flexion osteotomy, that would lead to an anterior position of 6 mils. So you see that the overall change in osteotomy is more than any good ligament could ever achieve. In other words, the bony position is the storm. The ligament is a tiny breeze. Okay? So let's take a look how the vets do it. And I didn't know that we had that profound understanding here on the table. So actually apologize for the poor images that I am now about to show you. But obviously we heard about tibial plateau leveling osteotomy yesterday, so I can skip some of those. That's what they do. They just change the slope. And it is obviously more effective than the ligament itself. Furthermore, obviously, docs will never follow rehab programs and so on and so on. So it's quite difficult to imply a normal ACL strategy onto a dog. But obviously, we heard yesterday that it may be possible when you brace it and protect your ligament. So how to solve these multi-planar issues now? Well, probably the next step to get this technically sorted is patient-specific guidance, because obviously it's complex enough to perform an osteotomy in one plane. Bringing it to 2 planes is technically very difficult. And therefore, probably patient-specific guides that are designed to match with multiplanar deformities would allow you to do this at a degree of precision that comes closer to what we all try to achieve. So that is a personal friend of mine, as everybody is showing sportsmen. So this is a personal friend of mine, Altin Lala, who played for Albania nationally and in the Bundesliga for my home team, Hannover 96. So obviously quite a varus deformity, and that was him playing in the Bundesliga with this knee. So you could now say, yeah, in the Bundesliga you can play with such a knee. Farmers League, but anyhow, that's high-level sports. So he got this ACL, and obviously that failed. But it didn't even only fail for the osteoarthritis levels. It actually failed completely in positioning the knee. So there is a huge anterior draw of the tibia. And how to solve this now? Well, it needs a biplanar correction. So there is two things you need to do. Obviously he needs an HTO, and obviously he hasn't played afterwards in the Bundesliga with this. That was treatment post-career. But you need to solve the issue of the medial side in order to actually allow him to keep this knee for another 10, 15 years. The task is not to actually keep this knee for the rest of his life. May it be, but it's unlikely. Nonetheless, that is the first plane that we address, frontal plane correction to get rid of this varus deformity. But the next plane that you need to address, as he had this posterior draw, is obviously the sagittal one. So this is an extension osteotomy in one go. And therefore you can see, I mean, if you look at this image where the femur rests on the tibia, and if you look at that image, then I guess you can see the difference. And I doubt that a ligament would be able to do that. There is other examples of such unfortunate cases where colleagues performed an osteotomy already, yeah, plus an ACL, and she was now lined up after 2 ACL reconstructions in 8 months for the 3rd ACL reconstruction, not seeing actually that she has a iatrogenous deformity that led to all the strain on the ACL, and probably she could have received 20 other ACLs, not solving the issue. So what you do in those cases, once again, is you change the slope and you change the frontal plane if needed. So these are multi-planar deformities. In post-traumatic cases, that is common. It's quite common. When you see a post-traumatic case and the patient is unhappy, well, just check if it was fixed properly. And if not, well, the answer is this. And what I technically do in these extension cases, I just leave the tibial tubercle on. I don't take that off anymore. And I do a biplane correction behind the tibial tubercle, leaving it in place, and then I correct it. And here you can see that the tibial tubercle is still on, and you hardly can see the osteotomy side. So in conclusion, bone obviously rules and goes before ligament, and the modification of the tibial slope may improve the sagittal stability. Obviously it does it, sometimes intentionally, sometimes completely unintentioned. So be aware of this, that there may be a flaw inside. Frontal plane corrections affect ligamentous stability at the medial and lateral side, and no ligament procedure, and that is very important, will survive your undergoing or underlying osseous deformity if it works against it. So we have seen that. Ligamentous stability can be improved directly and indirectly. So just think about the bone when you touch the ligaments, and as I said, it may be intentionally or unintentionally. And the more planes are involved, the more stabilizers obviously are affected, and please forgive me not touching the rotational profile. And lastly, that is so sad. That is so sad that it doesn't run. I wanted to show you the video of an elite sportsman who actually played in Poland for a soccer team on semi-professional levels back after his osteotomy on the slopes. But I cannot show you Conrad because the video is not running. Thank you so much.